So I have the privilege of introducing our next speaker, who is Dr. Mock. Dr. Mock is the Director of Global Surgery and a Professor of Epidemiology and Global Health at the University of Washington. He has training as both a trauma surgeon and an epidemiologist, where he has worked extensively in Ghana and was responsible for developing the trauma care activities for the WHO. Dr. Mock.
Well, good morning, everybody. I would like to discuss ways that we could improve surgical care worldwide, especially focusing on highest need areas. And I'll start by giving some examples from fields that I think have done this well, especially obstetrics, making maternal care safer, and to some extent trauma care. I will emphasize the role of the World Health Organization, where I previously worked for 3 years. And I'll also mention some examples from my own experiences working as a surgeon in Ghana for 4 years, 2 years in a rural area, Brakum, and 2 years in an urban area, Kumasi. And I'll give some examples of widespread improvements in surgical care for obstetrics and safe motherhood and trauma care, emphasizing the role of the WHO, and then wrap up with a few ideas about how we could expand that to these lessons learned from these fields to all of surgery. For the examples I'll give, there's been a similar approaches defining and monitoring the burden of surgical problems, defining essential services that would be most effective in lowering the health burden, death and disability from these conditions. Once the essential services are better defined, promoting and measuring the availability and quality of these services, especially focusing on population needs, not just what goes on in hospitals. Obviously, that's very important, but we need to know what is happening in the community. Many people dying or suffering from morbidity from surgical conditions without ever accessing care. And in order to accomplish much of this, we need to get political and promote access to care as a human right. So let's start with applying these sort of principles here to one field that's done it fairly well, efforts globally to lower maternal deaths. Many countries have made this a high priority, and most countries have a reasonable idea of the maternal deaths that happen in those countries. And when and there's well worked out methods for this. When vital registries are weak, there's fairly well developed epidemiologic survey methods to get reasonably precise estimates of this burden. So it's a field that has a good database to work for, good information base to work from. And it's fairly well known, fairly well documented that we've been doing moderately well with lowering maternal mortality. If you look over the past 40, 50 years, the absolute number of deaths has been steadily declining, almost cut in half. And it's been done using some of the steps that I mentioned earlier, clearly defining essential services and sort of the dual pillars of the safe motherhood efforts are a skilled attendant at every birth. Basically, that means a midwife in most cases, and rapid access to emergency obstetrical care when needed, especially for procedures like cesarean section or surgery for ruptured ectopic, etc. It's been fairly well worked out. What are the what are the resources needed to achieve this, such as different skill sets for different levels of providers, all the way from traditional birth attendants, midwives, general doctors who do the cesarean sections in rural areas in much of the world, and fully trained obstetricians. Physical resources, a big emphasis on promoting minimal but adequate blood banking, even in small hospitals. And then things that are less what you might call sexy and interesting for surgeons, but things like management and administrative mechanisms, such as maternal death audits as a quality improvement method to monitor and decrease preventable maternal deaths. And then a big hindrance to much of surgical care globally is poverty and inadequate funding. And the safe motherhood efforts have included ways to finance or pre-finance obstetrical care so it's more accessible financially. So all these things have been put together in safe motherhood efforts. including focusing on population needs, not only what goes on in the hospital. They've worked out well ways to address the so-called three delays: delay in seeking care, delay in transport for care, and then delay at the hospital or delay at the healthcare site. And there's been concerted global efforts to remove these barriers. And then in terms of politics, there's been high-level support for lowering maternal mortality. It was the subject of one of the Millennium Development Goals, which was very ambitious and not achieved, 75% reduction in maternal mortality, but it has been partially achieved, which is still fairly notable. Not a 75% decrease, but still a fairly notable decrease. And the work, now I'll talk a bit more about things that I directly work in, and much of what we've tried to do through the World Health Organization and several professional societies that I belong to is to try to promote similar efforts to what I just showed in obstetrics, promote similar efforts for trauma care. So in terms of defining and monitoring the burden, injuries kill around 5 million people per year, more than the total number of deaths from HIV, AIDS, TB, and malaria combined, so it's a huge health problem. A solution to it involves a spectrum of activities, including prevention, such as road safety, and improvements in care both inside and outside the hospital. In terms of how much, obviously there needs to be a big emphasis on prevention too, but there's still a lot that can be achieved by improving care. And as one example of that, I present some data here about what would be the avertable burden. That is, how much of the burden of death from trauma could we avoid or avert if we could improve care. And improved care means, in this case, lowering death rates for people that are already injured, so those that need trauma care, lowering the death rates or the case fatality rates that they experience, which are fairly high in low and middle income countries, and bringing those down to levels that we currently do achieve in high income countries. And here's just one example of that. This shows the mortality rate for seriously injured people, that is defined by injury severity score of 9 or more. That's a measure of overall injury severity, and it correlates closely with likelihood of dying from your injury. So if you take all these, if you take everybody with an injury severity score of 9 or more, 2/3 of those people died on this study. 2/3 died in Kumasi, Ghana, at the time a low-income site. About half died in a middle-income site in Mexico, but only 1/3 died at Harborview Medical Center, which you can see outside my window there, maybe through it's a bit shiny out there, but that's Harborview in the background. So if we could bring down those rates of death for people who are already injured, we estimate we could save around 2 million out of the 5 million trauma deaths that occur each year. So quite a substantial number. So we have a pretty good handle on the overall burden of death from trauma, and have a good idea of how much of that is avertable by better care. And so how do we define and promote better care? Well, first of all, I'd like to mention that any effort by outsiders, people living in high-income countries, or efforts by professional societies or efforts by the WHO should ideally add value to what's already going on. And there are a lot of people working on the ground in their own countries, really facing very difficult situations often, and doing really remarkable work confronting and removing the barriers that they experience every day. Here are just 3 brief examples. An ambulance service in a city in northern Mexico by improving training and the EMS infrastructure, training for paramedics, lowered mortality for injured patients transported by that ambulance service. Much of the world does not have ambulance services, but yet this innovative program in northern Iraq and Cambodia first aimed for survivors of landmine injuries in these post-conflict areas, but in a program that applied to all injured people, improved first aid capabilities, training of first responders, kind of what Dr. Wren was just referring to, remarkable decreases in mortality by providing just better first aid or any first aid in the field. And also simple things like quality improvement programs in hospitals have been documented to lower mortality, such as in the example of, from Thailand. So what I've worked on with WHO is trying to extend those sort of success stories from individual locations and institutions to try to accomplish those sort of things more globally. And one thing that WHO is good at is developing guidelines, especially for ministries of health, and promoting those through WHO's extensive network. It has offices in almost every country. And so it sought to promote better trauma care by delineating the resources necessary to provide a certain minimum but acceptable level of trauma care services, both inside and outside the hospital, defining better the human resources and physical resources. In much of this, we've tried to follow in the footsteps of what groups like the American College of Surgeons have done here in North America through things like its publication, Resources for Optimal Care of the Injured Patient, which defines resources for care here in North America. But what we've done with WHO is to take those resources, which currently are oriented for countries that have thousands of dollars per capita per year to spend on health, and make them realistic for countries that have $5, $100, or very low levels per year, per capita per year to spend on health. The pre-hospital trauma care systems gives advice to governments and institutions on how to institute and expand basic ambulance services, and what to do when those ambulance services can't cover an entire country, such as by training networks of first responders. The guidelines for essential trauma care give guidance about clinics and hospitals, defining 200 individual items of human and physical resources. In concept, they try to promote things like all rural clinics caring for the injured should have capabilities for rapid basic first aid, which many do not. And even though this is trauma care for much of the world's population, smaller hospitals should have capabilities for chest tubes and airway maintenance, certain minimum blood transfusion capabilities. This is the operating room at the Holy Family Hospital in Bekum, Ghana, where I used to work. And tertiary care facilities should have capabilities for emergency advanced airway management, which is currently problematic at many, and basic quality improvement programs, which most do not. These WHO guidelines have been used in many countries around the world, including, they were written primarily for low and middle income countries, but they've actually been utilized in several high income countries as well. They've been used for things like needs assessments to document deficiencies that can be targeted by low cost improvements. In some cases, those needs assessments have served as stimulus for action with documented improvements thereafter. They're increasingly being utilized in national health legislation related to both pre-hospital care and hospital-based trauma care standards. And we think we've done a reasonable job getting political on this. I mentioned before the Millennium Development Goal. We don't have one of them, or the newer version, Sustainable Development Goals. We don't have one for trauma yet, but we do have a few World Health Assembly resolutions. The World Health Assembly is the governing board of the World Health Organization. It consists of every minister of health in the world or their designees. It meets once a year in Geneva and adopts certain resolutions that call on countries to take certain actions, more or less voluntarily, but then do are required actions by the WHO. And I think we've been making some progress. The rate, for example, the rate of road traffic deaths worldwide has been slowing and seems to be plateauing. Obviously, we'd like to see things going down, as with the maternal deaths that I showed earlier, but for now, at least leveling off seems to be some progress. So let me briefly touch on how these examples might be used for all of surgical care. Well, right now we don't really have a good measure of how many people die from surgical related conditions each year. And what's the rate in low and middle income countries, what's the rate in high income countries, and what is the level of, what is the avertable burden if we could make surgical care perfect or as good as it is in the countries with the best surgical care. If we could extend that globally, how much would we achieve? We don't have a good handle on that. We're making some progress. You see an increasing number of articles such as this great study from Sierra Leone that did a household survey looking at how many people had surgical conditions that had disabilities or were suffering from a disease that could have been treated surgically, or how many people might have died from lack of surgical care. They made a fairly good estimate. We're seeing increasing numbers of studies like this, once again, seeing what's going on outside the hospital doors. We're also making some progress in better defining essential services. There's been a couple of, I'd say, significant landmark accomplishments in this, the Lancet Commission on Global Surgery and the Disease Control Priorities Project. The Disease Control Priorities Project is a global effort that involves WHO, the World Bank, and the Gates Foundation, and it's been going on in stages for about 20 years and is helping to define the best bargains in health, what is the most cost-effective interventions, and that would have the most effect on lowering rates of death and disability from any sort of condition. It addressed thousands of elements in the healthcare armamentarium, and it's defined out of all the potential surgical procedures, it's defined 44 that are the most procedures or sets of procedures that are the most cost-effective and really could make the biggest difference and are imminently achievable anywhere. Basically, the world has the resources and technology now to provide these services to every human being. Things like cesarean section for obstructed labor, cataract for the most common cause of cataract surgery to fix the most common cause of blindness globally, etc. And that these simple, fairly simple procedures could save up to 1.5 million lives per year if better distributed. In the same vein, the Lancet Commission has done a great job in defining some benchmarks, ideal surgical volume per population, what would be a minimum acceptable level of surgical providers, SAO, surgery, anesthesia, obstetrical providers, at which most of the population-wide effective surgery could be achieved. And there's an increasing number of studies kind of building on this. Prior to this, most low and middle income countries did not have a good handle on their own surgical volumes per year. That's been increasingly looked at, as in these studies. So finally, getting political, promoting access to care as a human right. There's a lot of science here, but it's not going to get achieved unless we really push to make it happen. Been increasing attention to this. A few years ago, there was a resolution, the first World Health Assembly resolution for the first time on surgery and anesthesia. So I think we've been doing a good job, a reasonable job, confronting the global burden of surgical disease. It's been done well for obstetrics and safe motherhood. I think we've made some dents in trauma care, and there's a long way to go for global surgery in general, but I think we're making some good steps. And the steps that need to be made are these: defining and monitoring the burden, defining the essential services that everyone should have access to, even in the poorest countries, and promoting and measuring the availability of these services, and getting political to make it happen. And I've talked a lot about sort of medical politics, World Health Assembly resolutions, and sustainable development goals. We need also to confront broader societal issues. Healthcare expenditures are limited by poverty, which is hard to fight, but they're also limited by specific rules by international financial organizations such as the World Bank, International Monetary Fund, and World Trade Organizations, specific actions by those organizations, keep many pharmaceuticals out of reach financially for many of the world's people. And there's also restrictions that many countries have placed on them in what they can spend in the health sector. And these sort of restrictions could be addressed by some things that are being debated currently: debt relief for the most heavily indebted poor countries, amending external restrictions on health sector financing, and more equitable and more transparent World Trade Organization rulemaking. But a huge thing we desperately need to address, which is rearing its ugly head and is already beginning to have very negative consequences, and that is climate change. This is my last slide, and I don't want to just leave people with a grim thought. Over the last, in my 40 or so years of working in global surgery or global health, I've seen a lot of progress in global health in general and in trauma and surgical care in particular. For example, the decreases that in maternal deaths that I showed earlier is very notable. But this progress is being threatened by several things, one of the biggest of which is climate change. If left unchecked, it will cause several major problems in health, one of the biggest of which is food security. A stable food supply is necessary for health. We can't accomplish much in global surgery if there's not adequate or nearly adequate food supplies. And this is now being impacted by climate change. We had been making progress in food security steadily over the past several decades with lowering rates of malnutrition. But in the past few years, rates of malnutrition, shown in this graph from the United Nations, rates of malnutrition have stagnated and even started to go up. This is unconscionable. In part, our lack of attention to this problem is inertia, but in part it's due to active disinformation being sown by vested interest in the fossil fuel industry and by the politicians that they control. For those of you wanting to pursue a career in global surgery, I strongly urge you to also take this problem on. The two conditions, global surgery and climate change, are intertwined. It's impossible to make progress in global surgery if the huge issues that surround us, including the world's food supply, are imperiled. So thank you for your attention. Oh, I did say this is the last slide, but I've presented a lot of work by a lot of other people. A little bit of it was mine and my colleagues, but a lot by a lot of other people. So I just want to give credit to the many remarkable people that I've worked with or whose work that I've seen and respected. So thank you for your attention. I think we have a few minutes.
Yeah, thank you, Dr. Mock. I'm going to go ahead and go to the questions now from our viewers, which I just want to put in a plug right now that if you're watching this online, please feel free to ask questions and we'll get to as many of them as we can. Okay, so first question is kind of a long question, so I'm going to break this up. So this is from Catherine. She asks, how can we improve bilateral relationships to improve training, access, and expansion of care that supports and empowers providers from low to middle income countries and high income countries?
How can we improve bilateral relations?
Yes.
Well, I think that needs to be done individually, one-on-one. A lot of my own work is, between my institution or me as an individual and institutions in lower and middle income countries. And I think on an individual basis, those of you that are, thinking to work in this, I put a big emphasis on respect for the local partners. So much of the time in global surgery, people from high-income countries are interested in things like getting a large number of, quote, great cases. All surgeons like to do great cases. But there needs to be an emphasis on making sure that like local training needs are being met, the needs of local institutions are being met. So deferring to the needs of local institutions is kind of paramount, in my opinion.
Thank you. So a question that kind of is related to this, but it's more, we have an anonymous attendee who asked, what are some avenues for people in the medical community, including trainees, to become involved in advocating for measures to stop climate change?
I think it's unfortunate. It's political. I mean, our elected representatives have a lot of power, but that, they are oftentimes beholden to those that contribute campaign finances, and they need to be nudged by other interest groups, including citizens. And I think it just gets down to bare bone politics and expressing your opinion to your elected officials.
Okay, so I have another question here. Kelly asks, do you have any success stories on physicians getting political in developing countries, not through like organizations such as the WHO?
Oh yeah, and in terms of not talking about broader issues like climate change or reducing poverty, but talking about services and getting countries, ministries of health, and other institutions to not change their focus, but take on it. For example, many ministries of health heavily invest in infectious diseases and such, which is, of course, very much needed. But they could also, at the same time, without taking resources away from the other issues, it can be ways to increase emphasis and increase attention to surgical issues. And I've seen that done in many countries. Almost all the countries I've worked in, I have seen improvements over time in pre-hospital care and surgical care capabilities at hospitals. Oftentimes that's what people do, doctors do at their own hospitals, but a lot of times it does need input from the government, especially pre-hospital care. And I have seen that gradually improving in many countries in response to day in and day out advocacy by the medical communities in those countries. So yeah, it is possible. And it helps to have reasonable goals, and especially to have goals that are really going to be effective. So much of the time, the advocacy that you hear about some advocacy goes in the wrong direction. For example, a CAT scan for someone's semi-private clinic or whatever. But I think much of the time the advocacy is where it should be, promoting improvements in care for whole countries. Can I switch back for a second to the prior question? Someone asked about climate change, and I mentioned about elected officials. By the way, am I still, my screen is being blocked by the questions. Am I still transmitting okay?
Yes.
Okay. Someone asked about how to get that taken up, and I mentioned about politics. And not to get partisan on this, but obviously one party is very much sort of pro getting things done for climate change and one not. And so I'd like to reach out to any of the people on this line who might belong to that other party that is sort of against climate change efforts now. And obviously, if you're interested in global surgery, you probably have humanitarian motives. One thing that's desperately needed is people on the right who dismiss climate change, who are willing to confront climate change denialism and get political actors on the right engaged in confronting this problem.
Thank you, Dr. Mock. I think we have one last question here. This is going back to Catherine's question. It's kind of a two-part. So she's wondering how we can better utilize and maximize resources already available and streamline resources like need assessments into international and local health systems.
Some of the stuff that I showed from the WHO work was on that theme. Oftentimes, with the same amount of investment, the same sort of dollar amount, you might say, if you spend it in an organized and careful fashion, it will go further, obviously. So one of the things that I think the WHO has done well is develop the guidelines for trauma care, both in hospital and pre-hospital, that are the most cost effective. And so needs assessments that show deficiencies in low cost but effective and important items really are a good way to identify problems, shed light on them, and often get them fixed at very little cost.
Hey, thank you so much, Dr. Mock. That was really awesome.